This is my name, address, email address. Anybody can email me at any time. I'll try and answer them as quickly and expeditiously as I can. And then our website's a little bit archaic. It's about 5 or 6 years old now, and we've been wanting to update it, but we were trying to get some of the legal issues in North Carolina cleared up. We had a big hassle with the board a couple years ago, advertising as mercury-free, and I don't know if everybody heard the story or not, but they said if you have mercury fluorescent bulbs in your office, you couldn't say you were a mercury-free dentist in North Carolina. So at this point, I think we're a little bit safer to do a little bit more advertising about that. So my subject today is going to be biologic dentistry and incorporating CEREC into a biologic dental practice, and how it is what I would call a marriage made in heaven. So that's my topic today. And if anybody knows my personality, you know I like to go on Google and look up some pictures on topics. And so I looked up marriage made in heaven on Google, and this was the picture that came up on the top of the list. And this is more of a yin-yang marriage in heaven, whereas CEREC is more of a symbiotic relationship. I'm a recent convert over to CEREC and computerized dentistry, and I've been a biologic dentist now for about 5 or 6 years. I'm not a CEREC instructor, so don't expect me to explain a lot of really complicated CEREC stuff, because we do just a lot of bread and butter CEREC in our office. We don't get into really complicated stuff. So I'm basically a wet-fingered biologic dentist like pretty much everybody in the room here. My previous attitude about CEREC, and I think this is also true of a lot of guys and girls who don't want to get into it, they're a little bit hesitant, is because we all thought that the first generation of CEREC doctors were a little bit like aliens, and they were trying to talk us into becoming CEREC doctors, and you got to really try this stuff because it's the best thing since sliced bread. And so I was always hesitant a little bit about making the jump into especially investment. And by the way, this is what the CEREC blocks look like that go into the machine that eventually become your inlays, your onlays, and your crowns. The really neat thing about the Sirona block is that it is a polychromatic block. It has a dark edge to it, a medium body color, and then a translucent color. And you're able to move your crown up and down in that block before you mill it out. So it's a fantastic option as far as aesthetics goes. I found the CEREC or the Sirona blocks just show the best aesthetics of any of them. How many people in this room have CEREC? Because I'm going to take 3 segments here. The first is a real quick CEREC 101 of those who don't have CEREC that are interested in getting into it. Then we'll talk a little bit about the extraordinary advantages that CEREC brings in the field of biologic dentistry, and especially with now the controversy about bisphenol A, chemicals that are in the materials that we're using. And then I'm going to go over some case histories and do a little bit of mechanics for everybody to show you exactly what it's all about. So this is the acronym that CEREC represents. If you're making your $2,600 a month payment for the machine, you'd probably change it over to expensive, but that's the one they came up with. This is the acquisition unit, which you can see right here next to the podium. And it's about the size, of the air filter in the room. It doesn't take up a whole lot of room. Guys who are really CEREC fanatics, you can work out of 2 rooms with 1 machine if you put a UPS power supply on your CEREC. But Patterson will tell you it'll void the warranty. So they always say, take your UPS off your machine if a Patterson repair guy ever comes by. And this is what the new XL milling machine looks like. They built it really large on purpose because they wanted to be able to expand. They want to be able to add some cutting heads to it later on, and we'll talk about that a little bit. It's really neat the way they have all the supplies all incorporated in the design. It's really clean. And this has quickly become the social area of our office, because when patients have a CEREC crown being made, the first thing they do is they walk out in the waiting room. Oh, you got to come see this. Dr. Denver's making my crown. Come on, they're doing it right now in the office. And they all get really excited about it. So it's the most interactive thing in a dental office you can imagine. The patients are really entertained by it. And the first thing I learned the hard way is that the CEREC milling machine is a lot like an Etch-a-Sketch. And remember, when we all played with Etch-a-Sketches as kids, you could draw vertical lines, you could draw horizontal lines, but then someone said, oh, you can make a circle with it. Then you got to go, oh, no. Now I got to coordinate my 2 hands together and be able to cut a curve. So you think about that with the cutting head. It can cut really well in this plane as the diamonds move back and forth cutting on that ceramic. And it can move really easily like this in and out. But to cut on a diagonal, it's got to go click, 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 click. It's got to be able to combine those two mechanisms together. So you have to understand the ergonomics of computerized dentistry in order to give the machine something it can make as a successful crown. And this is also true if you're doing lava crowns in your office, if you're doing the CEREC in-lab, if you're doing any kind of milled computerized dentistry, it's all the same. We don't have a robot that can work in all three planes at one time. First off, the three biggest disadvantages, the initial startup cost, and I included a $12,000 laser in that price, which we still got sitting in the box. We haven't had time to go get training on that yet. We purchased a laser, a Serona laser at the same time. So I think it's for $111 or about $108 you can get a unit now. The second disadvantage is the learning curve. You've got new software to learn in your office. If you're computer literate, you've got a lot of toys in your office already, it's pretty easy. You have a few changes in your preparation. The logistical change was one of the biggest challenges for us administratively, because what happens is you go from having all these prep and then 3 weeks down the road delivery, prep, 3 weeks down the road delivery appointments. And if you use EagleSoft the way we do, we make every different type of appointment a different color on the screen. So you have to get used to getting rid of your single crown delivery appointment times, but the advantage you'll see in a little bit is everything becomes production once you get rid of those deliveries. It took us about 4 months to make those changes. And then there's a lot of maintenance with the machine. It's just kind of maintenance free, but you have to really keep up with it. You got software updates, brand new materials come online. And in mentioning that, they say the Serona people are trying to work with pure hydroxyapatite. They're going to try and culture it and form it into a block to where you will actually be replacing enamel with enamel pretty soon, which is very exciting stuff. You have new CE courses you have to take, because every time you take a CE course, you can learn how to do veneers, anterior crowns, all kinds of stuff. And they say within a year we'll be able to take a digital impression for a bridge on this machine, email it to the lab, and then the lab can start working on it that day. And then you have a little bit of upkeep on the milling unit. The next advantage of CEREC is that you don't have to use impression materials anymore. You eliminate the conventional impression material. As Carmen and I, my assistant, say, we don't use the goopy stuff anymore. So patients just love not having to have the impression. And the acquisition unit consists of basically an infrared camera that has a prismatic lens. And this is one of the two babies in our office. We have two babies that nobody ever drops. What's the first baby? The sensor for the digital radiography. You never drop that. And this is the second baby in the office that nobody ever drops, because this is a $12,000 piece of equipment, and nobody in my office wants to work free for 6 months to pay back for the new camera, right? And by the way, this is my staff right here, so if you see them nodding their heads at me. Another neat thing about the Serona camera is that the engineers were smart enough to put a little heater on the side of it. So as long as the machine's turned on, the camera's being heated up. So you go to put it in the mouth, and you don't get that fog condensation on the lens. So they really thought that out. Of course, when you're being left-handed, it makes it a little bit harder to grab it. The next advantage is that everything's one appointment. So you come to think about it, how many people have problems when you prep a crown, you charge it out, you send it form to the insurance company, then you get this little nasty letter back. We need the delivery date of the crown. We can't cut you a check until you write in the delivery date and send that back to us and wait 2 more weeks for you to get the check back. With CEREC, your prep and your delivery date are the same date. So all those insurance hassles you have with delivery time, they suddenly disappear. Okay. Also, again, the way we had it coded on EagleSoft, green was production, green means money, so it made sense to make it green. Blue might have been a delivery appointment. So suddenly you had green, blue, green, blue, green, blue, and then all of a sudden you go to green, 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 green all the way across the schedule, and all those delivery appointments are dead. Basically, we all know when you deliver a crown, you make no money on it. The patient's already paid for it. It's another appointment. You got to numb the patient back up again. So all those dead appointments become production. The next thing is you have total control over the design, which we'll show here in just a minute. And then finally, one thing I wanted to point out as a biologic dentist is the advantage of the composition of the materials. There's really no outgassing of chemicals after this material is placed in the tooth. It's pure feldspathic porcelain, very biocompatible. And as you see, there may be a little bit of agent coming off the bonding agent, and I think we're going to go from composite to bonding sealants and then probably to bonding agents and cements after that with our study with IAOMT. So we'll get the background information on that hopefully pretty soon. University of Michigan found out that this did bring the tooth back to what they calculated to be 103% of the original structural integrity of the tooth. You put a large composite in a molar, you're probably going to have a weak tooth. But CEREC is the only material that they found now that brings it up to that level of strength. It does test very good on our MSA tests. And as you'll see in some of the pictures here, it's a very easy material to adjust and polish. If you really have a lot of extra time, you can get a glazing oven and glaze it, but that adds about another 20 minutes to your procedure. It is a fine-grained feldspathic porcelain. Vita and Serona make the two feldspathic ones. You can get it reinforced with lucite. You have the exact same crown as you would if you ordered an impress from the lab. And the composite blocks were used a lot. The new software doesn't have it on it yet, but they're getting ready to add it. And the advantage of composite is you'll be able to make a crown to fit an implant. And I heard this morning that Serona's has taken their three-dimensional software on their new Galileo's pan. You'll be able to place an implant, scan it with a CEREC, make your composite crown, and load it right away here pretty soon. So you're going to be able to go from no tooth, place an implant, put the analog on it, scan it, glue the crown on, and you're done. So here's what I looked at when I first started looking at this system. Our office manager and everybody started talking about it. And if you look at the number of single crowns you do a month, you add in the lab fee, the cost of the impression, temporary materials, the 2 appointments, maybe an hour to prep and 30 minutes to deliver it. Occasionally you have to re-cement a crown, and occasionally you have to remake the crown for a patient who the color's not right or the fit's not right. And the neat thing about the GE financial system that we work with is they give you 6 months, no charge, no interest, that doesn't add on to the final note. And so that gives you 6 months of a learning curve time. You get to use the machine, you get to get your speed up, you get to incorporate it in your office before you actually start paying for it. So I know it's a little bit of a hook, but it worked for us. Then you compare that with the cost of the blocks, the training, and the frustration, the guys who put theirs on eBay after using them for 6 or 8 months and decide it's not for them. And this will be with the lab. 90 minutes of overhead at $250 an hour. The cost for your impression material, your trays, other materials by registration material. What your lab charges you for a porcelain crown. And maybe a 1% remake at a total of $765. Now, patients never see this figure. All they see is the $1,000 that goes on their check when they hand it to the secretary, right? And a lot of the employees who work in dental offices don't understand this either, that every time you're making a crown with the lab, that's about what it costs the dentist in the office to make it. So you have to take all this into consideration. Compare that with the CEREC, and I amortized, if we're doing 40 crowns a month, take the lease on the machine divided by 40, so your machine costs you $65 every time you use it. The cost of your block, your contrast spray, your cement, your diamonds, office overhead in 1 hour, because we're going to do the same thing in 1 hour instead of 90 minutes. That's the total. So you're charging $1,000 a crown. Would you rather make, one profit or the other? It's pretty self-explanatory. And then having total control over the procedure is really priceless. How many times do you order an A2 crown and you really needed to have an A3? And when you glue on the upper bicuspid, it stands out like a sore thumb. What are you going to do? Well, I'm sorry, Mrs. Jones, we have to anesthetize you again. We're going to have to take another impression. You have to wait 3 more weeks for the right color to come back. With CEREC, within 5 minutes, you've taken a new, you don't even have to take another impression. You just go ahead and mill it out. Pick a darker block, stick it in there, and you got a darker crown. So I wanted to go over just a few CEREC preps and show the basic morphology of the prep. You don't want a molar that looks like a cowboy hat. You want a molar that's like an English bowler hat. It's got to be fairly flat on top. And why is that? Remember, I talked about the milling head. The milling head can do this and it can do this, but it's hard for it to do that. So if you give it a flatter surface, the inside of your crown is not going to have as many irregularities to it, and it's going to fit a whole lot better. I prefer to have a little bit more down near the cervical. I really cut that 1.5 pretty much all the way down because I don't like to have a thin margin. If you're off with CEREC, if you're off any more than about 3 degrees, one side is going to be thick and one side is going to be thin. So if you give yourself an extra 0.5 millimeter at the cervical, you have a little bit of scrunching room in there to cheat if you have to. Second thing is you need to be able to visualize these from the occlusal and have an equal distance between the teeth on either side. And we're going to talk a little bit more when you're doing composites how that plays a factor. And everything has to pull. You have to have a path of insertion where it's going to fit in there nicely without binding. Okay, the very typical scenario. 5, 8 years ago, we would have cut the mercury out, put in some composite, prepped it for a PFM, cut all that enamel away on the buccal, cut all the enamel away on the lingual, and make a nice pretty PFM to maybe match the one behind it, right? First thing, remove the amalgam. We use a 245 burr, just a basic disposable 90-cent burr. Use it, throw it away. Don't worry about the decay. Don't worry about anything. Just get the mercury out. The next thing we do is I've got a diamond burr that looks like a trash can. It's got a little bit of a taper to it. It's flat on the bottom. It's flat on the sides. It's got about a 7-degree taper. And I just get in there and I play like I'm Forrest Gump and I'm just mowing the yard out in Alabama. And I go back and forth and back and forth and I make that just as flat as I possibly can. You want it to be like a flat pancake. I had to use Alabama, didn't I? Then I go back and forth, back and forth, back and forth. And I'm just mowing the yard, making it nice and flat. But the whole thing is I'm saving all this enamel, and I'm only going to replace the broken part. I'm not going to replace the good part. Glue that on with some nice translucent cement, and it just virtually disappears in the tube. And if you talk to Gary McCowan, another IAOMT member, any of the other guys that work with teeth that are hopeless, we all pretty much say the more enamel you cut away, the greater chance you're going to have to do a root canal on that tooth. Because you're going to expose a lot more dent and tubules to bacteria. You're going to remove more insulation from that pulp, and it's going to lead to problems later on. This was a doctor who posted this on CEREC online. I was kind of impressed because he must have spent an hour just getting the floss and getting it all ligated and making it look pretty for the picture. But this is the sort of thing you can do in one visit. You can do multiple quadrant restorations in a single visit with this technology. But you got to get the tooth in a way that the camera can recognize the prep. And in our office, once I get the mercury out and we get ready to smooth the tooth out, this is what you hear. And this is what you hear for about 10 minutes because you got to shake this powder for at least 5 to 10 minutes to get the particles distributed. And the good news is I just told my girls they got new powder that doesn't have a little ball in it. So it won't sound like Lowe's anymore at Dr. Young's office, shaking the paint up. First, you got to get the tooth wet. Then you've got to put the powder on it so the camera can see it. Pretty much all the European dentists who are doing CEREC have gone over to this system, which combines the powder and the liquid. It's just like spray paint. The disadvantage is for 4 ounces, it's $200. So you're paying $200 for 4 ounces of baby powder. So next, what I wanted to do is to capture an image so everybody can just kind of get a feel for what it looks like. And if everything works okay, like it did a minute ago, first thing you do is you tell the computer what tooth number you're going to do, which is the tooth number up here. And for reasons for being expeditious, I went ahead and had that all done ahead of time. There's 3. It's just like flying an airplane. You got 3 different X, Y, Z axes. You have to get the yaw correctly. Then you have to get the pitch correctly. Put the camera right dead center in the tooth, and then you work on your roll. You got to be able to see all the axial line angles at one time. You hold it steady if you're not mercury toxic, and then you save the image like that. Next thing you do is you go on the tooth behind it. You try and get the same angle. You try and get the same yaw, the same pitch within a few degrees, and you save that. The next thing you do is you go on the tooth in front, and guess what? It's prepped for a crown too. You want to try and see all the axial line angles. Go along the axial angle of the tooth. Save that one. And then finally, you want to be able to capture the tooth medial to that. And so how long did that take compared to mixing your polyvinyl, putting your adhesive in your tray? packing the cord, going through all that, to take an impression compared to this. So at this point, you would take a bite if you're the type of dentist who takes bites on his crowns. I found, however, if I can save a cusp or two on the teeth, I don't have to take a bite, because if you've got a cusp, yes, Marcia? Well, you do, but if you can keep it dry, you don't need as much clearance as you would for a polyvinyl. If you can see it visually, you can draw it. Okay? I wanted to show you just all the controls you have. You can move the model around just like you would if it was in your hand. I center the first tooth that I want to work on right in the middle of the screen, and I want to blow it up with this tool. And then if you left-click on the model, you can move it in all three planes of field. Okay? Now I'm going to tell the computer where I want the ceramic inlay to go. And so you simply take the mouse and you go all the way around the tooth on your margins, just like that, until you come back to the same spot you started. And now you've told the computer exactly where you want to go. Now, if you see any irregularities in your line, like right on that corner, it's a little bit wobbly, you double-click on one side of the little wobbly spot, and then you just redraw it. Remember, with ceramics, you want everything smooth. You don't want any wavy lines. You want all your internal line angles to be smooth and continuous. So now we're going to tell the computer, okay, we're pretty happy with this. It's a pretty good design. Let's see what the computer can do. Another thing I tell patients is one of the best dental ceramists in the country, Lee Culp, did all the anatomy, did all the morphology for this software. He built 38,000 teeth that's in the hard drive in this computer. And in some modes, you actually get to use worn dentition, young dentition. You've got four or five different libraries to work with. And now we have a proposal. So remember the good old days of dental school, you'd cut your model in half. You'd wax it up. You check for the contacts between the teeth. And this particular button allows you control over how much contact you're going to have with the adjacent tooth. I can add porcelain to it. I can subtract it if it's going to be too tight. I can smooth it. It's just like drawing it on a computer, basically. So now we're going to go ahead and tell the computer to get ready to make it on the milling unit. And if you'll take some time to go talk to the Sorona people, they'll show you what the milling unit looks like. You have control over where the sprue is going to go. But this is the neatest thing since sliced bread. I want to make this onlay, and I want to make the crown at the same time. So I'm going to tell it, yeah, I'm going to make tooth number 12, and it's going to be a crown, and I want to use the database for that. And this is the hardest thing for a dentist to do. Because you don't touch the machine until it completely cycles. What it's done just then is it has virtually seeded the first restoration on the model. So now the computer knows that tooth is ready to go. And I'll take all your questions at the end, so write them down if you got one.
There's also the form at 5 o'clock.
Oh, there is? Okay. Yeah, there's a form at 5 o'clock. So now on this particular, it just opens the computer up in a different screen. So I've told the computer where the center of the restoration is right there. And I'll tell it to fix it. And then you go through the exact same process. You go ahead and mark your margin where you want the margin to go. This automatic margin software works pretty good some of the time, but sometimes you got to play with it. And if you can't see it on the model, you hit the space bar and it gives you a grayscale. So let's say you got a little bit, like Marcia said, if you got a little bit of contamination you can't quite see, you can grayscale it. And with the grayscale, you can really see it good. Can everybody see that all right? Same thing. This is how long it takes for you to design a crown. So it's remarkable. Now it's going to ask me, well, what happens if the tooth's not quite lined up with the tooth in front of it? Well, you correct the axial inclination like that. You tell it, okay, I'm happy with that. And here's where you get a check for the different libraries. I'm going to use an adult tooth instead of a youth. And within 30 seconds, you have your next crown ready to go. You have to mill your first unit on the software before it lets you mill the second one. And at this point, this is when you start sending this information to the milling unit. Then you're going to adjust your contacts, check your marginal fit. I go ahead and polish all of the proximal, facial, lingual side of the crown. We check the aesthetics, make sure the color looks good, and then we go through our little dance where we do our chemistry experiment. Carmen will put the chlorhexidine and the bonding on the tooth while I etch the porcelain. The bonding agent with multi-link acts as an accelerant when you go to seat the crown on, so you've got 20 seconds to clean that margin. If you don't, it's rock hard, so you have to really be fast with it, and then you check your bite at the very end. Okay? So this is for the bread and butter of biologic dentistry with the CEREC, combining CEREC with composite. The first part of this is what we do every day. This is, like I said, our bread and butter. You get local anesthetic, you isolate it, take out the mercury, you work on your unsupported enamel, and you round off all your sharp edges. So this is a nice case that we did a couple weeks ago. We're going to do composite on 15, CEREC crown on 14, composite on 13, CEREC on 12, and an amalgam on 11, all at the same time. Did I already say you could do all this at the same time? Well, sound like Dr. Jaffe. So now we got the amalgam out. We're going to composite, composite, composite. Make sure your pulpal floors are nice and smooth. Double check for undercuts, and then we go from a black diamond to a blue and then to a red. So at this point, we got the composites done. I smoothed some flowable at the top of that root canal so we'd have a nice smooth floor, and got that ready for the inlay. And a project like this would take us about maybe a couple hours to do. Patient does not have to come back to get the crowns delivered. No temporaries, no sensitivity. They walk out with a permanent restoration. So what did you decide to do first? You're going to do your crown first. You're going to do your composites first. Do you have soft tissue problems? Do you have root proximity problems? Do you have big open contacts on all the old stuff? So we tend to do the CEREC first if there is root proximity problems. If you're doing an MOD on 13 and it's hard to see that margin on 14, go ahead and image 14 while you got a direct shot with the camera. You don't have that edge of the old amalgam hanging over your crown margin to worry about. And so if you do have roots that are right on top of each other, go ahead and do your CEREC first. If you've got really deep proximal margins and your margins are very close to the biologic width and you're getting ready to pack a little bit of cord and there's no room for the cord to go in there, do your CEREC first because you want to be able to visualize that with the camera. You got a really long clinical crown, path of insertion, you got a bicuspid erupted crooked, it's kind of hanging over 20 degrees compared to the molar. Think in terms of which is the first thing to do best. If your composites are really wide, especially for your matrix, you may want to do those first, and that way you've got the only opportunity to polish that whole proximal surface of your composite while it's wide open. Okay? Remember also that the proximal contact control is done with the color on the CEREC like I just showed you, and with the wedging when you're doing your composite. So you have control either from either side. You can make the CEREC thicker or you can make the composite thicker. Decide which is the one to do first and then use it as a backup. And I got this from Dr. Wilson. There is no Betty Crocker for any patient. You have to customize a treatment plan for every single person that you see. And remember, a leaking composite box won't do you any good 2 years down the road when it's got a big hole in it or a porosity. So if you can get direct access to that box with your light, do the composite first. So these are some combos. We're going to do 2 composites and a CEREC. This MO on number 14 had some decay on it. Take all the mercury out. Go ahead and do the composite on 15. Get ready to image 14. Now, the reason why I want to do 14 first is there's a big difference in the depth of my margin. You see how tall up that margin is and then how deep that margin is? If I'd done the composite first, it would have been harder to image for the CEREC. So now we've done the composite on the back, we've done the CEREC in the middle, and I'm getting ready to do the Paladin. Now, I fell in love with Paladin almost as soon as I started using it. If you try and do regular matrix here and you're wedging the heck out of it, you're still going to have a flat composite. It's not going to look right. It's going to pack food like heck. So if you do the CEREC first, put your Paladin on, make sure you've got good 4-point contact. 1, 2, 3, 4. Put the Paladin man on there that's got that nice biconcave surface to it, and you're going to get a nice closed contact right there. Switch around, do your mesial, and then you're done. So now we're going to actually compare apples to oranges, all right? For that particular case, actually it was 2, 3, 4. We're going to do 2-surface composite on 2. We're going to do 3-surface composite on 4. The CEREC onlay on 3. And if you came to my Tucson lecture, you know that we do charge a hazmat fee in our office to remove mercury. I tell patients it's just like taking asbestos out of your attic. And if you come in here with a cavity, I'm not going to charge you for it. But if we put $40,000 in filters and equipment to do this the right way, and this is our way to recoup our investment on our filters. So we have a McDonald's picture menu that we print out on our laser printer, and we hand out to every patient that we do mercury removal with. And it shows the mask, it shows the air filter, it shows the rubber dam with the oxygen on the patient, and it says you're going to see a hazmat fee on your treatment plan, and this is what this is all about. I don't think we've had a single mercury removal patient that's balked at it, not a single one. Because once you educate them and let them know how dangerous this stuff is, and you go through it step by step and show them the steps that you're taking to make this safe for them, this is not going to be a problem. So this is the total fee. It took us 90 minutes. So that's the cost of the block, the overhead, and then this is your profit per hour when you divide the math out. Okay? Compare that with what you would have made if you'd paid, $240 for the crown and you had to have another 30-minute appointment. Here's another case, composite, CEREC composite. There's an old PFM crown in the middle the patient wanted to hang on to for a while, so we get the mercury out. And the first thing I started doing is I look at this interproximal distance. It's a little tighter here, got a little bit more room right here, so you're going to kind of judge that when you get ready to take your image here in a minute. Got the composites done, a little bit of hemorrhage here. I think I had the pack cord for this one. I just put a little bit of hemat down there and dried it off and didn't even have to pack cord for this case. Make sure your axial line angles are nice and round and that you have no sharp edges there. If you've got a sharp edge, what's going to happen is you're either going to have some enamel break off or you're going to have some CEREC break off. And I'll show you when you're done with your prep. I should have it down here somewhere. Let's see. When you're done with your prep, everything should be nice and smooth. And that's the purpose of that flat diamond. You just go back and forth and back and forth. And this was the same prep that I showed you earlier, okay? Save as much of that enamel as you possibly can. Another question I get asked all the time is how well do these things fit compared to what the lab does? The XL milling unit will mill you a crown within 7.5 micrometers of what the tooth is. The very best polyvinyl impression is going to give you 21 to 25 micrometers. So these things actually fit 4 to 5 times tighter or better than what you're getting from the lab. Okay. This is what it looks like with the old powder. We're going to switch over to the color powder that smells like spearmint here next week as soon as we get back. And so it's blue now instead of white. And then again, you use a nice translucent cement. You glue it on the tooth, and it literally just disappears in the tooth. And once it's polished, our polishing technique is we go with the blue diamond to take out any little swirls from the machine. Then the red diamond, if we have to. Go directly to a white stone. We use a Brasler silicone wheel and then an Axis yellow polisher. And I didn't put that on here because I wasn't sure how much time I would have to show the polishing. But once you become a CEREC user, you get this really thick catalog of all the possible ways to polish a CEREC. And you basically have to take a couple courses and experiment. But we have patients come back to the office and they say, Dr. Young, this tooth is so much slicker than the tooth behind it. This feels like sandpaper now. Can we do this in CEREC? I want to make an appointment while I'm here. kind of beginning to wind it down here. I got about 10 minutes left. This is one of the larger combinations we did in one day. 2 composites on the 2 upper teeth, 2 CEREC inlays or onlays, and a composite on the lower. I'm going to take the mercury out. And here again, you got to pay real special attention to these axial line angles. You have to have nice divergent walls. I try and carry that diamond just in a single plane, and I just work it back and forth like that. So that way I know at least the inlays are going to seat right next to each other. And so if the tooth's off a little bit, just tilt the diamond to correct that so they all line up really nice. We're getting ready to powder it now. Some doctors say they even put the rubber dam on while they powder and impress it. We have pretty good luck just getting it dry with 2 mirrors. I'll hold 1 mirror on one side, and Carmen, my assistant, will hold the mirror on the other side. We have a roving assistant who will shake the can for us, and she knows I'm getting ready to polish it with that last red diamond. We holler at her, and she starts shaking. So we've got the can shaken, we've got it polished, we've got it retracted, dried off, powder it, and then the rover will hand me the camera. And so we're doing 6-handed dentistry at this time, and it really speeds the process up. If you're trying to hold the tongue back and you got to reach over for that $12,000 camera, and then all of a sudden you've got it crooked in your lap and it falls on the floor, then you just kind of want to go home and drink a beer. So now the inlays fit really nice. Check for flossing. Go ahead and etch them and glue them on. So economically, one more time, how does this compare with what you pay for the lab? You have your 2 CEREC onlays, 2 one-surface composites, 1 two-surface composite, the hazmat fee. That generally, I change that according to how much mercury is in the mouth, how much time I think it's going to take. 2 hours of overhead materials, divide that into 120 minutes, and that's what your profit per hour is. Now, you can maximize this even more. If you're Dr. Moore and you've got 2 rooms, you're doing 2 CEREC patients at the same time. Plus, you're checking your hygienist who's making production too. But if you're like me, I'm a little more conservative. I don't want to get quite that busy, but you can still overlap your times. So for your time economics, that last 20 minutes while the unit's being milled, you go check your hygiene, check your second hygiene, get your next patient numb, come right in and glue the crown on. So while the crown's being glued on and polished, your next operatory patient's being numb. Okay? You dismiss that patient, say, goodbye, Mrs. Smith, hope you enjoy your CEREC. I'll see you. And I'll walk right in the next room, wash my hands, and start working on the next patient. So your roving assistant's cleaning the rooms ahead of you. You're overlapping your appointments by about 20 minutes on your EagleSoft, whatever your software is. So you can easily break $1,200 an hour in your production with your restorative, and then all your hygiene is gravy on top of the potatoes on top of that. So it really adds a lot of time economics and advantage to the office if you're doing that. So what's the future of CEREC? I see down the road a lot of large composites that were first, second generation composites. They're losing their bond. They're getting sensitive. Patients can't chew on them anymore. They're wearing out. This fellow is a German engineer who works at a local ceramic plant. And I said, well, you can have a larger temporary plastic filling or you can have a permanent ceramic restoration. He said, well, I want the ceramic. This is unbelievably fast. It takes all of 45 seconds to take the composite out, another couple minutes to polish it, another 3 or 4 minutes to image it, and it's milling probably within about 12, 15 minutes. This is what the CEREC looks like when it comes out of the machine, and you see the little sharp edges here? That's the sprue. You have the artistic freedom to place that sprue on the crown or the restoration wherever you want to. And for these little ones, we just leave it on there because you grab it with the cotton forceps and you can just pick it right up. You know, there's no reason to even take it off yet. Go ahead and bond them, and then you cut your sprue off when you're done bonding and polish it. And he wanted to hang on to his wisdom tooth a little while longer. I told him he had a cavity in it, but he decided he didn't want to lose his wisdom anytime soon. So I wanted to thank you for having me today. I think it worked out about just right on time. Thank you.
Thank you, Dr.
Thanks again, everybody.